followed by the pound sign. I'm sorry, we did not get your name. After the tone, please state your name, followed by the pound sign. I'm sorry, we did not get your name. After the tone, please state your name, followed by the pound sign. There are 3 parties in conference, including you.
Hey there.
Good morning.
Good morning.
Hi,
This is
Kevin.
How are you?
I'm fine, thanks.
Good.
We're just getting started.
Good. I'm going to put you on mute so you don't hear my road noise.
Oh, okay.
Have fun. Thanks.
Thanks. Now we start from the beginning. Kevin, so since you're on the road, you can't see what we're presenting, can you?
No, I can't.
Okay. Good morning. Good morning. Do we have anyone else on the phone? Okay. All right. Well, we're going to go ahead and get started. It's 10 o'clock, and I'm sorry to say that we only have 2 people here, and I think only 1 person on the phone. Is there anybody else signed in yet? Anyone else on the phone?
Hey, it's Tammy.
Hey, Tammy.
Hi, girlie.
I'm Janice Jones. I'm the manager of Child and Patient Access.
I'm Lisa Dudley, the manager of Crane and Franklin Memorial, and we're going to talk about the CHAA examination today and give you some information and give you some focus on what it is and what to study for. So we'll go ahead and get started.
Right. If you'll introduce yourself.
I'm Ursula Moore with Central Patient Access.
Okay. Hi, Ursula. Hi, Ursula. And Dawn, we know you. All right. First off, we're going to show you how to get into the NAHAM website. You just go into your intranet and you sign on to the NAHAM website. And you click into your certification, and it'll bring up the CHAA and the CHAA. And what you want to do is to click on the CHAA, and it's slow. All right, there we go. All right, so you click on the certification, then you click on your CHAA. And first off, it'll give you the testing window and application deadline. Now, since we've already passed the January and the April, so you would apply for it in May to be tested in July, and so on and so forth. And it costs $100 for members and non-members. And, of course, that's to be seen in the future, whether we're going to be able to put that in budget or not.
What we're trying to do is spark interest and to tell you and inform you about the CHAA, what it is, how it can benefit our jobs with the knowledge, and hopefully we can spark some interest and we can get some folks that are interested in taking the CHAA, and we can have more in-depth study groups as we go along. Today's an introductory course.
Right.
So if we choose to do it in July, we're on our own as far as paying.
Exactly. Yes. Yes, unfortunately. And before you apply, you might want to go down and print the certification guide for your certification.
You can do that right from the site.
Right, you can print that.
That's no cost.
Right. You just go back
Before you apply.
Right. Go back to your certification. You click
Janice
on
and Lisa,
Yes.
I'm sorry to interrupt, but for the sake of those on the phone, can you repeat the questions? It's hard to hear them.
Oh, I'm sorry.
No problem. Thank you.
Sure.
Ursula had a question. If she took the examination in July, would it be on her own? And at this point, we said yes, it would for July, that we are just currently trying to spark interest for a future examination, perhaps after October.
All right, so you go down here before you apply, and you'll see here, it's the candidate guide to certification. You click on that, and you can print it from your site, and it does give you tips and how-tos and what to look for during your examination. This is a real good tool, very good tool. So, and I'm not going to go through that because it's a process. But
it's something you'll have to read on your own.
Yes. But it's like I said, it's a very good tool. And what we want to start off doing is take you through a slideshow that Lisa has done. And I'm going to go to that.
Hey, Janice.
Yes.
Do you all have something that we should be able to see on a web thing?
Yes.
Because I can't see anything.
You can't see?
You see any? I only see that me and Lisa are signed into this one. Can you see anything, Lisa? Or am I missing something? I just have something that says nothing's currently shared, but I see the lNAHAM Certification CHAA.
You do?
Yeah. Maybe it's just me. I'll try to log in again.
Well, maybe it's just me. Oh, there is nothing shared. So I want to share. There we go.
Janice, Lisa, you got it?
Oh, you got that?
Oh, thank you.
You're welcome. I didn't share it with anybody. I was being selfish.
I thought it was me.
No, we're acting like it was April Fool's. Now go to,
Okay. All right.
okay, today we're going to talk about a little bit about the CHAA examination itself and give you some focus areas, and then we're going to have lots of time for questions. We'll try to answer as many questions as we can. If we can't answer them, we will certainly find the answers out.
Right.
The CHAA basically is in three. When you get your study guide, it's in three parts. The first part is our pre-encounter. The pre-encounter, it tests your knowledge when interacting with internal and external departments, as well as handling angry staff, angry patients and staff behaviors. You will need to have the communication skills to connect with age-specific patients while maintaining respect and privacy. Customer service plays a role throughout the entire patient experience with the pre-encounter and the encounter. A lot of the pre-encounter and the encounter during the study guide is a lot basically about customer service. A lot of the stuff we talk about today will be very familiar to you because we live it and we breathe it every single day. When me and Janice were practicing, we were like, this is so familiar, we do all of this. And it's so familiar because this is our job. This is our profession. And believe it or not, a lot of this stuff you already know. There's a lot of terminology that will have to be learned, but a lot of this stuff we already know. So we're talking about the pre-encounter. In access services, customers often have expectations for good customer service. Traditional concerns are wait time, delay time, noise level, pleasant smiles are all related to good customer service. However, there are other things to consider, such as clinical concerns and patient needs, financial concerns for the patient, insurance, verifying coverage, patient financial services, sound familiar? Customer literacy and comprehension, resource scheduling, documentation. We have to take into consideration when we're doing the pre-encounter, when we're doing the pre-registration, the patient check-in, admission, and the registration process, the medical record initiation, collection, storage, and the dissemination of patient information. Patient rights and responsibilities always play a role. Clinical prerequisites, financial clearance, regulatory requirements. We have to abide by EMTALA, Joint Commission, as well as be in compliance and abide by our HIPAA regulations.
And the part 2 would be the encounter, and that's one of the most important things that you can do during the encounter is gather the positive identification with legal name, date of birth. However, all the following must be taken into consideration. Number 1, customer service, patient check-in, admission and registration, explaining and obtaining that consent form, and patient identification, special needs, patient placement, infection control, hand hygiene, all demographic information. And gathering demographic information has both clinical and financial purposes and must be complete and accurate. And data such as your legal name, the date of birth, social security number, address, phone numbers, employer, emergency contact information. And, of course, the HIPAA, the privacy, that's very important, very important. Patient rights and responsibilities, the important message from Medicare, insurance and payment information, Medicare, third-party payers, managed care, medical terminology, wayfinding, and we do that every day. Customers come up and ask us, how do they get to patients' rooms? That's wayfinding.
That's your signage.
That's your signage. And then the patient tracking. And levels of care are established at the encounter part of the registration, and different types of levels of care are the acute care, observation, outpatient, emergency, ambulatory services, specialty clinics, recurring services like your physical therapies, diabetic teaching, long-term care, and in our case, it's our swing bed, respite care, and hospice.
In the study guide, the third part is future development. Future development is actually, after we complete the registration, it's our data integrity. It refers to the process of ensuring that our data is consistent, and it's a consistent process that measures our data accuracy through the customer satisfaction, performance indicators, benchmarking, productivity, and other factors. Other factors that we use are surveys, performance improvement tools, staff education and competency, which we do that here with Carillion very well, technical competencies, clean bill drops. We want to make sure that everything that we do on the front end creates a clean bill to drop so nobody else has to touch the claim, and it'll go through and we will get reimbursed quicker. Reduction in time spent for auditing by management. That's data integrity. Errors corrected earlier in the revenue cycle. We want to make sure that all of our errors are corrected as quickly as possible so the bill can go out so we can be reimbursed as quickly as possible.
And there's a glossary of terms that'll be in your guide, and there are 150 terms that we use every day. And if you just go through these terms, study them, and I know it sounds easy, but when you're taking the test, I know for me, for instance, I panic, but I passed, and it's something that you just got to think, I do this every day.
So, every day.
Yes.
It is words, it's terminology such as accepting assignment, advanced beneficiary notice. What is that? The APC, the ambulatory payment, appeals, birthday rules, charity care, CMS, the UBO4, compliance, diagnosis-related groups, our DRG. You know, what is that and what do we use that for? Terms such as emancipation, medically necessary, the OSHA. What does OSHA stand for? Occupational Safety and Health Administration. Peer review, PCP, what is PCP? Primary care physician. Revenue cycle, UBO4, waiver. There's in the study guide, there's a glossary, and there's 150 terms that actually you will just need to study and memorize. The test is multiple choice. So if you study your study guide, which goes over the three things that we talked about, the encounter, the pre-encounter, the encounter, and the future development, and you study your medical terminology, then you will have a very good chance at passing the CHAA.
And if you go in and you print off that candidate guide, it will help you tremendously.
But you will have to read it. You do have to study. You'll have to read over the guide. I think it's 178 pages long. When you read it, you're going to be pleasantly surprised. Stuff you already know. We're already in the access service field. We already know this stuff. Maybe it's just putting it into technical terminology.
Now, we've got some sample questions. What does MPI stand for? Exactly. What does JCO stand for? Exactly. We always get a little scared whenever JCO comes around, but we always pass.
What is an improvement tool to compare performance to another organization called? That's benchmarking.
Flat sum amount that patient owes with each visit is called what? Right. And what does ABN stand for? History. Exactly. Right.
So those are some questions of typically what would be on the CHAA exam. Like you said, it's all multiple choice. You do have to read the study guide. You do have to study the medical terminology.
And there's good references in the study guide. Good references.
And the exam is not open book, right?
No, it's not open book. You would typically you have a proctor. You can go to one of the NAHAM conferences to take it, or you can have a CHAM who's a proctor. Now in our system, Janice Jones is a proctor, myself and Lisa Wade, so we would be able to give those tests. Now, some people may say, well, why should I take the CHAA? What will this do for me? Well, personally, for me, I studied things and I remember things on the CHAA to this day that I will never forget. It gives you a broad scope of access services. It rounds out your knowledge, and it benefits you in so many ways. The terminology, it just really, it makes you feel good to pass it, to know, I am certified in my profession. I know what wayfinding means. I know what a UBO4 means. I know what these terms mean, and it makes you feel good and gives you confidence in your job. So personally, you could set it as a personal goal. You can take the CHAA, and you're certified in your profession to do what you do. So it can really benefit you.
And when you do get certified, it's a renewal every 2 years. And it doesn't cost $100 to get renewed. And I'm just hoping that we have a lot of people that are going to be interested in doing it.
Have you taken the test recently, or has it been a while?
It's been several years since we've taken the test. Now the study material, it's basically, it has increased. Yes, it has increased, but it's basically the same information. Maybe a little bit has changed, but as I was reading over it, I was very surprised. It's basically the same information. Like the UBO2 has changed to, the UB92 has changed to UBO4. They've updated some terminology, but basically, and surprisingly, there's a lot about customer service and patient experience, which is not surprising, throughout the whole guide. Yes.
Is there any questions that you would like to ask? No? Yes, you can. And like I said, I'm very thankful that you have came in, showed some interest in it, and I do hope that we get more people that are interested in it.
Spread the word, because
Yeah.
if we get a group that's willing to take the exam, we can do more in-depth study groups and focus.
Right.
That's what we did. We focused. We had flashcards, but you do have to put the time in to studying and get yourself familiar with the guide and the terms and so forth.
Exactly. So I guess that will conclude this part. I do have some sample questions that I'll hand out to you, and I also have like a word search puzzle that I'll give out to you if you'd like those. Okay? All right, and
Did we have any questions on the line?
Lisa and Janice, can you go through some of the sample questions and some of the specific terminology pieces that you think may be regular part of our work, but maybe we don't use the terms every day?
Okay, sure. On the terminology, I'll go first, and then Janice can ask some questions later. On the terminology, there are terms such as Part B Medicare. You would need to know that Part B Medicare or Medicare supplementary insurance helps pay for the doctor services. It's the doctor side, outpatient hospital care, durable medical equipment, and some medical services that are not covered by Part A. So you will need to know the difference between Part A, Medicare, and Part B, and that Part B is for outpatient or physicians. Participating physician, we would need to know a physician contracted with the payer's managed care program to render services to members of a primary care or specialty care physician. Things such as the patient bill of rights, what is that? That refers to consumer bill of rights and responsibilities, a report prepared by the President's Advisory Commission on Consumer Protection and Quality in the healthcare industry. We would need to know what per diem means. Per diem is a negotiated daily payment of delivery of hospital services. You will see that a lot of these terms actually roll right into the revenue cycle. So it's not just for patient access. It's for, it actually goes through the whole billing cycle.
Lisa?
Yes.
Back to the other one, the consumer protection, the patient bill of rights.
Yes.
I don't know if you have that there in front of you. Are there any examples of what some of those points are?
The patient bill of rights.
Yes.
It's the right that is subdivided into 8 general areas that all healthcare consumers should be guaranteed and describe the responsibilities that consumers need to accept for the sake of their own health. I would say it was part of the patient's rights and responsibilities, but it's the patient's bill of rights. It's their rights when they come into the hospital. Such as their responsibilities, it's their rights from their perspective.
So that's related to the form we give them.
Yes.
Is that right?
Patient rights and responsibilities. Yes.
Thank you.
You're welcome.
all right, and some of the sample questions we've got. For instance, which of the following statements is true about Medicare Part B? A, all Medicare patients have Part B. Medicare Part A patients may enroll in Part B and pay a premium. Employers enroll all employees over 65 in Medicare B. All senior citizens are automatically enrolled on their 65th birthday. Right, it's B. I actually kind of got a chuckle out of that one. The acronym ABN issued to describe. Exactly. And these are all multiple choice. So, mailing maps to a patient prior to services and placing directional signs in a facility are examples of Right, wayfinding. A patient has fallen in the hospital and is complaining of back pain. Which of the following is the most appropriate response? Exactly. Initiate the hospital response chain. A new patient is registered by patient access staff for outpatient visit and is then admitted. The patient realizes after 2 days that their name is spelled wrong and the date of birth is off by 1 year. Who is most affected by this error? Right, everyone.
And I'll go back to some more terms since we have plenty to go over. For example, you would need to know what reimbursement means. Reimbursement is the amount of cash paid to the hospital by patients and third-party payers for health care services. What respite care means what is respite care? Respite care is short-term care provided at home in a long-term care facility, at a community-based center, or in a hospital when another setting is not available. Respite care allows families caring for elders or other mentally or physically dependent family members time to give off for their caregivers. This type of care is not reimbursable through Medicare and Medicaid. So you have to know when that patient comes into the hospital and they're under respite care that that's not reimbursed by Medicare. We currently have patients that happens to. They're in a hospice situation and, the family needs a break. They can no longer take it anymore, so they'll send the patient to the hospital, and then they're put in as a respite care patient. Self-administered drugs, they call them SADs. What we encounter these on the billing end, and those are self-administered drugs or oral or topical medications identified by Medicare as drugs that can be administered by the patient in an outpatient setting and are not payable by Medicare. Examples are aspirins and an antibiotic ointment. We currently encounter those every day with Carillion. The Medicare patients will come through the ED, and they will give them an aspirin, or they'll give them nose drops or eye drops or some kind of ointment, and none of those are paid by Medicare. So we get calls, and we have to be able to go and tell the patient exactly what medication that they took and explain to them that it's not covered by Medicare. However, they can have it covered by their Part D Medicare. They have to mail that in themselves. There's a process for that.
Did you specify that's for outpatient only, correct?
For ED, yes, that's for outpatient only. If the patient is admitted to the hospital, all of those self-administered drugs become covered. However, if it's an observation status, they do not. That's still outpatient. So,
that's a great point.
Yes.
And a lot of times our patients, nobody thinks to inform our patients of that.
Right.
Even though they're able to bring their medications, actually they're asked to bring their medications with them so that the doctor can see what types of medications they're taking and be familiar with that. They're not allowed to take the ones they bring in because of liability issues.
Right.
And so the pharmacy, they put an order in, we provide it from our own internal pharmacy, and they end up having to pay our hospital pharmacy prices out of pocket, which is a challenge for people.
Right. Yes, it is.
That's a good one. Thank you.
You're welcome.
And I have a couple more questions, sample questions. An example of an advanced directive is assigning variable power of attorney for health care, a will directing disposition of personal effects, a directive assigning benefits in advance of receiving medical services, written permission from a parent to treat a minor patient. Yes. This is assigning variable power of attorney for health care. Now, in regards to insurance coverage, the term deductible is the percentage of the bill the patient is responsible to pay. amount the insured is responsible for before the insurance pays, percentage of the bill the insurance company will pay for services, maximum amount a patient may earn to be eligible for medical.
Amount the patient pays.
Yes, yes. And like I said, I've got copies of these, and I'm going to give those out to you.
Just a couple other terminologies. You would need to know what capitation means. Capitation, a fixed rate of payment to cover a specified set of health services. The rate is usually provided on a per member, per month basis, regardless of services that are actually rendered. That's capitation. You would need to know what the birthday rule is, which I think our trainers go over that pretty well. That's a rule used to determine whose insurance is primary for a child covered under both parents' insurance. Both insurance carriers must follow the birthday rule. The parent whose birthday falls earliest in the calendar year becomes the primary insurance, and the other would be secondary. If both parents are born on the same day, the parent whose insurance has been in effect in the longest is the primary insurance. So that's the birthday rule. A couple of things that probably don't look familiar to us.
Hey, Lisa.
Yes, sir.
Sorry, I want to jump in about, to go back one to the capitation.
Yes.
Because I wonder, can you read that definition again? I wonder how well that, how easily understood that formal definition is. And I might be able to give an example.
Okay. Capitation, a fixed rate of payment to cover a specified set of health services. The rate is usually provided on a per member, per month basis, regardless of the services that are actually rendered.
So, yep, go ahead. Sorry.
That's the definition.
Yeah, okay, I thought you were going to say something else. So, if you are, as we see more potential with capitation processes coming back, in the past, we used to see it more frequently, that a patient's account would have a capitation adjustment on it, basically saying that regardless of all the services we provided and how much those charges were, we're only going to get paid a certain amount, and so the rest gets adjusted off.
Right.
And I'm about to go through a tunnel, and I will probably signal, so
All right.
I'll let you all continue.
Okay, thank you.
Thank you.
We're seeing more and more capitation, and I think years ago we knew it was coming, and it's here. So
It's just like Medicare has a cap for physical therapy patients. They only pay $1,800 at the therapy, so that's all they'll pay. So that's an example of a cap.
The capitation, is that what the insurance company is setting? Is that what you're saying?
Yes.
The insurance company is saying, this is all I'm going to pay
This is all I'm
this
going
month for this service.
Exactly.
Okay, gotcha.
it's their agreement. Other things such as basic words that I think we all know, such as appeal. An appeal is a special kind of complaint made when a beneficiary or a provider disagrees with decisions about healthcare services, typically related to payment issues. There is usually a special process used to appeal payer decisions. So that's, we know we do appeals, and in billing they do appeals, but that's the definition. APC, ambulatory payment classification. We would need to know that's the system of averaging and bundling using current procedural terminology, CPT codes, in order to pay for the service.
And let's see, I have a couple of more questions. The purpose for gathering financial information from patients is for Hospital and physician billing, exactly. The federal agency responsible for the administration of Medicare and Medicaid is the Centers for Medicare and Medicaid Services, CMS. That's the answer.
Exactly. Terminology, you would, of course, need to know what coinsurance is. Coinsurance is another payment amount the third-party payer can identify as patient guarantor responsibility. Coinsurance is usually a percentage of the total billed amount. Collection agency, an outside vendor that collects payment on hospitals under a contract with the hospital. The hospital refers an account to a collection agency when they're unable to collect the account themselves. The collection agency charges a fee for the money collected and usually based on a percentage. With Carillion, we have a collection agency syndicated. Like I said, all of this stuff, you know, we live it, we breathe it every day. It's just a matter of studying it, put it in perspective, knowing what your definitions, what your terminology is. EMTALA, you'll need to know, of course, what EMTALA is. EMTALA is our Emergency Medical Treatment and Active Labor Act. The Emergency Medical Treatment and Active Labor Act is a statute that governs when and how a patient may be refused treatment, one, transferred to another hospital, to another when he or is in an unstable medical condition, two, and it's also known as the anti-dumping law. So have to be very familiar with EMTALA is. End-stage renal disease, ERS, we see this on our Medicare MSPQ. You'll have to know what that is. Exhaustion of benefits. You know, these terminologies, there's 150 of them. Is there anybody on the line or anybody, do they have an acronym or a terminology that they would like for us to answer or try to answer? Anything?
All right. Here's some frequently asked questions. This one is, if I don't pass one section of the exam, can I take that part over, or do I have to repeat the whole examination? If you don't pass the examination, you will have to take the entire exam over again. Will I be told what questions I missed so I can study that part more thoroughly for the next exam? No, you don't. Each candidate will receive the score reports providing information about their exam performance. Included in the score report will be areas in which you may wish to focus your studies. The report will not list the specific questions that were answered incorrectly. And how soon after I take the examination will I receive the results? Candidates that take it online will immediately get your score.
Yes.
And when I took it, we did paper, pencil and paper, I had to wait. So that's nail biting. So this is really good. You'll get your score immediately. So. And when can I take the examination? The revised examination will be offered quarterly for a period of 1 month. They will be offering during January, April, July, and October. Candidates may arrange with their proctor to test any time during these months. And your proctor cannot be your immediate supervisor.
Right.
It has to be right.
Lisa Wade, Janice, and myself. So I think that we're pretty spread out to where if anybody wanted to take it, we would have a proctor.
Right.
Again, I just want to give you my personal benefits when I took the CHAA, how it really does help you broaden your knowledge in your profession. It kind of puts things in perspective in a whole circle about from the beginning, the pre-encounter, all the way to the end, to the data integrity and the surveys. And we kind of live it and breathe it every day. And I think we've done a really good job with Carillion with our training, and Captain, how he has directed us to our surveys. And I mean, we live and we breathe this every day,
Right.
and, you know, it's just certifying us in what we already do. So, I hope that there's a lot of interest and that we can
Right.
get a group together to take it. And boy, would it look good on your evaluation.
Yes.
It said that you had a goal to take the CHAA and that you took it and you passed it. That would be an incredible
That'd be
accomplishment for
Yes.
you. And, you know, I can't say enough but how it will only benefit and help you in your knowledge.
It will. And Ursula, are you still certified for the CHAA? You're not?
We were all required at one time.
I see. Right.
Yeah.
Yeah, I remember
Several
that.
years ago when we get away from it, and we would like to get back into having an interest and taking a CHAA. And it'll take a little bit of time, but I think it's certainly doable.
Exactly. So if anyone else has any questions?
So it costs $100.
It costs $100.
And what's the renewal?
And the renewal fee for the CHAA is $25.
Oh, okay, every 2 years.
Right.
And the thing about the renewal is if you put all your information in Cornerstone, all your education, you can, if you archive it, you can print it out and it'll tell you your credits, and that is acceptable to NAHAM because I just sent some renewal education in. So it's, you have to have a certain amount of CDs.
Right. You have to have 30.
But
30
Cornerstone
hours.
keeps up with it. So if you put all your education in there, you can keep up with it pretty well through Cornerstone, and it actually adds it up for you.
Mhm.
And they do accept it.
Right. Just print out your transcript. All right. If there's
Kevin, are you still on the line?
I am.
Okay, good.
I have a couple things. I first off want to thank both of you, Lisa and Janice, for pulling this intro together. I think it's been a wonderful introduction to what the exam will entail and what we have to do to make that happen, and even the benefits. And during Patient Access Week, I think this is such a key time to reintroduce the CHAA and talk about all of that. And it really is a tool to demonstrate your knowledge and your commitment to your profession, as Lisa said. I'm really impressed with what you've shared in this. The other thing is I'd love to hear from those that are on the call or in the room there with you, what pieces, as we try and develop this introduction further, can you think of any things you'd like us to make sure we include next time?
anything extra?
Besides, and I mean, we're probably going to look to have more in-depth, rather than an introductory class, more in-depth with some of the sample type questions.
Right.
But besides that, for just the introduction, are there any things you think we could add?
Is there anything that you guys think that we could add to the presentation, maybe for a class? If we can maybe get more people together for a class? A game?
A game, right.
Dawn has a suggestion about doing a game, flashcards, things
Cool.
like that.
Yeah,
That would be great.
Yeah.
Yeah.
That's how I studied. We got together study sessions, and we had flashcards, and we called questions out, and we made it fun. You have to make it fun to keep your interest. Jeopardy. They do have crossword puzzles and word puzzles, but you have to interact with somebody to make it fun and make it interesting.
We just kind of work off of each other,
Right.
asking the questions. So, all right.
Very
Anything
good.
else?
Thank you, guys, and I hope that you
Thank
tell
you.
your colleagues that to certainly come this afternoon because we're going to be doing this presentation again. And, I mean, you can sit and listen, and we can learn about it and what it is. And, this is free, and
We do have more
we
time.
want to spread the word and spark interest.
Yes. All right.
Thank you, guys.
Thank you very much.
Thank you. I'll see you later.
Bye.
Bye-bye.
Take care.
Have a great patient access.
Thank you.
Thank you. You too.